Hi everyone, my name is Lauren Schleicher. I'm the current PGY2 ambulatory care resident, and today I'm going to be doing my girl presentation over the 2021 STI Guideline Updates. My objectives after hearing this presentation is being able to identify commonly sexually transmitted infections and knowing how to treat them, discussing updates to the 2021 STI guidelines and the literature that prompted these changes to be made, and then last but not least, being able to develop treatment plans for patients with STIs from various patient cases throughout the presentation. Just as a disclaimer, some slides do contain some graphic photographs, and I will do my best to forewarn you before going to these slides. So first, I just want to start off by differentiating the difference between a sexually transmitted infection, STI, versus an STD, or sexually transmitted disease. So sexually transmitted infections are infections that have not progressed to that disease state. It's transmitted during sexual activity, but it may not always progress to a disease. So for example, about 80% of people are exposed to HPV, but most cases go away on their own without causing any health problems. So this would be an example of an STI. However, if a patient who is exposed to HPV, if that infection develops into like genital warts or cervical cancer, this is the point when it's considered an STD. So really that STD is that progression from that infection to actually causing a disease. According to the American Sexual Health Association, a growing number of public health experts believes the term STDs can be misleading to people because disease suggests that a person has an obvious medical problem, which is not always the case. And so that is why STI is the preferred term and it's considered more accurate. So next we're going to review some of the most common STIs and treatments. Just as a forewarning, we are not going to go through all STIs, just the common ones that we may experience in clinic or in that hospital. So the first one we'll talk about today is chlamydia. So chlamydia trachomatis is a gram-negative bacteria that is the most frequently reported bacterial infectious disease in the United States. In 2019, a total of 1.8 million cases of chlamydia infections were reported to the CDC, making it that most common notable infection in the United States. It has been reported to be on increasing number of cases with about 2.8% compared to rates from 2018. About 2/3 of patients, 61%, report that chlamydia cases are most common among persons between the ages of 15 and 24. As you can see on the graphs here, where most age groups do fall in that younger age range, as well as most of them being females. As far as clinical presentation, most patients do present asymptomatic. Only about 10% of males have symptoms, which may include dysuria or discharge, and about 5% of women present with symptoms. The most recommended test for these is going to be a nucleic acid amplification test, or a NAT test. And this is because it has the most sensitivity for screening and diagnosis of genital chlamydia. It is recommended that women have a cervical swab compared to a urinary swab, and that's because it is more sensitive for those females to have a cervical swab. It's also important to note we do not want to test patients too soon, as there can be a false positive, so typically it's recommended to wait at least 5 days after exposure for that test. Given that most of our patients who are diagnosed with chlamydia are between that ages of 15 and 24, it is recommended to screen anyone under the age of 25 that is sexually active for chlamydia. We only are really typically screening patients above the age of 25 if they are considered high risk, and that are people that have new sexual partners, multiple sexual partners, or sexual partners that have multiple sexual partners. Similarly, for men, we are screening for high risk, with the only difference essentially being men who have sex with men. For chlamydia treatments, doxycycline is the agent of choice at 100 milligrams twice a day for 7 days. This is a change to the guideline that we will discuss later. Previously, azithromycin 1 gram was also an appropriate treatment regimen, but this has recently changed. However, it still remains an appropriate treatment patients that are pregnant or patients that are under the age of 8 years old, given that tetracyclines are contraindicated in that patient population. For infants and neonates, we still recommend the use of erythromycin-based or ethyl succinate-based therapies as well. It's also recommended that patients do abstain from sex for 7 days during treatment, and it is recommended to also be retested again in 3 months. So our first assessment question today: what is the preferred regimen for treating chlamydia? A, levofloxacin 500 milligrams daily for 7 days. B, doxycycline 100 milligrams twice a day for 7 days. Or C, azithromycin 2 grams times 1 dose. Awesome. I see lots of B's in the chat, so that is correct. So this is the big change to the guideline. Doxycycline is going to be our first go-to agent for most patients. Depending on the circumstances, there may be a few exceptions to that rule. Our next patient case, we have a 20-year-old female presenting to the emergency room that has noticed white vaginal discharge for about the last week, but she denies any bleeding or tenderness. However, she does have a known history of chlamydia infections. She was diagnosed today with chlamydia and bacterial vaginosis. What medication regimen should we use to treat her? A, azithromycin by itself. B, azithromycin with flagyl for 7 days. C, doxycycline 100 milligrams twice a day and flagyl for 7 days. And then D, doxycycline monotherapy. And for this one, I know we haven't talked about bacterial vaginosis, but I do see some C's coming through the chat. So that is the correct answer for this one as well, where flagyl is the treatment choice for bacterial vaginosis, and then reemphasizing that doxycycline is our go-to agent for chlamydia infections. Next, we'll move over to gonorrhea. So Neisseria gonorrhea is a gram-negative bacteria. That's the second most common bacterial communicable disease in the year. In the US, it's estimated that 1.5 million new cases of gonorrhea infections occur each year. And rates of gonorrhea have increased about 92% since historic lows in 2009. During the 2018-2019, the overall rate of reported gonorrhea infections did increase about 5.7%, and the rates increased similarly among male and female, all regions in the United States, and among all racial and ethnicity groups. Since 2013, the rates of gonorrhea have been higher among men compared to women. So on the graph on the left, it represents the rates of reported cases by sex, showing that men are more affected than women. And then the graph on the right shows the estimated rates of gonorrhea by men who have sex with men who have sex only with women, and then women. And this is per 100,000 people. And this estimated rates was based on weighted analysis of data from interviews among random samples reported to gonorrhea cases. The higher cases of rates among men is thought to be due to either increased transmission or actually increased risk of ascertainment through actually better screening techniques, especially in patients that have sex with men, or a combination of both of these things. The graph on the left also demonstrates that the estimated rates of reported gonorrhea among men who have sex with men are 42 times the estimated rates of men who just have sex with women alone. Very similar to chlamydia, gonorrhea is typically asymptomatic. Men are more likely to have symptoms, whereas women are normally always asymptomatic. Once again, also diagnostic testing is different between men and women. Urinary swabs miss about 50% of cases in females. That is why cervical swabs are recommended in this patient population. Next, I will warn you, is our first slide of pictures. So the picture on the bottom left shows what potential discharge may look like for men that are diagnosed with gonorrhea. And then the pictures on the right show disseminated gonorrhea. So disseminated gonorrhea is rare and infrequent, and it results in these particular pustuloacral skin lesions on the patient's skin. So how do we treat gonorrhea? So the treatment of choice for gonorrhea now is 500 milligrams of ceftriaxone given as a 500 milligram IM dose. And this is given for patients that are diagnosed with cervical, urethral, or rectal gonorrhea. The only time patients would be given a higher dose is if they weigh over 150 kilos, and they would be given a 1 gram dose of ceftriaxone. Old guidelines had recommended always treating gonorrhea and chlamydia infections because they commonly occur together. However, new data supports only treating for chlamydia if it's not excluded. And that would be going with doxycycline 100 milligrams twice a day for 7 days. Alternative agents, if you have a cephalosporin allergy, and it's important to point out that the risk of a penicillin cross-reactivity is highest with first-generation cephalosporins, but is rare, less than 1% with third-generation cephalosporins, such as ceftriaxone. Other antibiotics, like if you have an anaphylactic reaction to cefepime, it does share the same R1 side chain as ceftriaxone, so that would be more of a cause to potentially use the alternative agent, would be gentamicin as a one-time dose, as well as azithromycin. Sometimes if ceftriaxone administration is not feasible or available, you can do the oral cephalosporin Syphilis 800 milligrams given as a one-time dose as well. Our next assessment question, what is the preferred treatment regimen for a gonorrhea infection for a normal 85 kilogram person? A, Syphilis 400 times one dose, B, ceftriaxone 250, C, ceftriaxone 500 milligrams, or D, azithromycin 2 grams. Awesome. I'm seeing lots of C's, so that is correct. So this is the new change one of the new changes in the guideline that we will discuss later, but 500 milligrams is pretty much the standard dose for most patients. Next, we have a 45-year-old male that reports to urgent care. He's having dysuria and increased urinary frequency, and he's had multiple sexual partners in the last couple months. He does have a notable allergy to amoxicillin, which he had a couple years back that developed as a rash, and he weighs 85 kilos, and he was diagnosed today at urgent care with having gonorrhea. What medication would you recommend this patient starts on? A, gentamicin with azithromycin. B, ceftriaxone 500 milligrams. C, azithromycin 1 gram. Or D, 1 gram of ceftriaxone. Awesome. I'm seeing lots of B's coming in the chat. What is going to be correct? So even though this patient did have an allergy to amoxicillin, the likelihood of a cross-reactivity between the 1%, and so it is recommended to continue using ceftriaxone for this patient. Next, we have a 36-year-old male that presents to the emergency room. He denies any discharge, any painful urination, blood in the urine, or testicular abdominal pain. He does have an allergy for cefepime, which is anaphylaxis, and he weighs 109 kilos. He's never been diagnosed with any STIs in the past. However, 2 weeks ago, he did have sex with a female partner, and during their sexual intercourse, his condom did break, and his partner just called letting him know that she was diagnosed with chlamydia and gonorrhea. Which would be an appropriate treatment for this patient? A, doxycycline for 7 days, in addition to gentamicin and azithromycin times 1 dose. B, doxycycline for 7 days, in addition to ceftriaxone as 1 dose. Or C, azithromycin for 1 dose plus ceftriaxone for 1 dose. So this one is actually going to be A. Given that this patient had an anaphylactic reaction to cefepime, we would want to avoid using ceftriaxone in this case and avoid cephalosporins. So gentamicin and azithromycin would be the recommended treatment for gonorrhea. Even though azithromycin had previously been used for chlamydia infections, given that the rates are not as effective with azithromycin compared to doxycycline, it still would be beneficial to treat the patient for a 7-day course with doxycycline for chlamydia. All right, next we'll go into Trichomonas. So Trichomonas is the most prevalent non-viral STI worldwide, and it is caused by a parasite. Only about 30% of patients that are diagnosed with Trichomonas actually develop symptoms. And as I'd mentioned with chlamydia, where most patients are under the age of 25 that are diagnosed, Trichomonas is actually one where older women are just as affected as younger women, and they unfortunately define older women as people over the age of 25. As far as diagnosis, we want to do that NAT test is that it's highly sensitive, and wet mounds are very low sensitivity, only providing about 44 to 68% sensitive results. So the treatment for Trichomonas differs between males and females. So for females, it's recommended that they are on Flagyl 500 milligrams twice a day for 7 days, whereas males are on a 2-gram dose times 1. About 1 in 5 people who are infected with Trichomonas will get reinfected again 3 months after treatment. And so it's really important that these patients are getting checked after 3 months of after initiation of treatment to make sure they've not been reinfected. Currently, nitromidazoles are the only class of medications with clinically demonstrated efficacy against Trichomonas. And luckily, there's low rates, less than 5% of flagell resistance to Trichomonas, showing that potential host factors may be involved. Alternative regimens include tinidazole, and it's both 2 grams orally for 1 dose for both males and females. Studies have looked at tinidazole, and they have been found to be equivalent to metronidazole in achieving parasitological cure and symptom resolution. However, it's usually more expensive, and that's why it's typically recommended as an alternative agent. Pelvic inflammatory disease, or PID, is an infection of the female reproductive organs, and most often it is actually caused by patients that were diagnosed with an STI, in particular chlamydia and gonorrhea. Those 2 STIs actually account for about 50% of pelvic inflammatory disease. There are other causes of pelvic inflammatory disease, including gram-negative rods, H. influenzae, anaerobes, and strep agalacticae, as well as CMV. Most often, pelvic inflammatory disease occurs when a sexually transmitted infection is spread from the vagina to uterus, fallopian tubes, or ovaries, and that typically occurs when patients are unaware that they have these STIs. Luckily, in most recent years, cases attributed from STIs leading to pelvic inflammatory disease have been decreasing, which is encouraging. And it's important to note that treatment for pelvic inflammatory disease will not undo damages that have already been done, but rather just preventing any worsening from happening. There are going to be different treatments for pelvic inflammatory disease depending on if it's going to be IV or more of an outpatient treatment. But what's important to note is that all regimens used to treat pelvic inflammatory disease should also be effective against gonorrhea and chlamydia, just because negative endocervical screenings of these organisms does not rule out upper genital tract infections. So that is why all these regimens you can see here, with the preferred regimen being ceftriaxone plus doxycycline and flagell, ceftriaxone covering gonorrhea, doxycycline covering chlamydia, and then metronidazole covering your anaerobes. Treatment duration is going to be a little bit longer in these patients, which you'll notice here on the oral and IM treatments, which are more for our outpatient use. Treatments are typically carried out for about 14 days in this patient population. Human papilloma virus, or HPV. There's actually over about 150 types of HPV identified, but only about 40% of these types of HPV infect the genital area. Types 16 and 18 account for 66% of all cervical cancers, whereas 31, 33, 45, 52, and 58 account for about another 15%. Types 6 and 11 cause over 90% of most genital warts, and the hallmark symptoms are going to be cauliflower-like bumps. And I do apologize, we do have a graphic pictures coming up here. So as you can see on the screen here, the pictures on the right and the middle are a lot more severe cases of what chlamydia presents as. And so it's important to point out that the one on the case, which is more likely what you would see in clinic, compared to some of these more severe untreated HPV treatments. There's various ways that HPV can be diagnosed, looking at abnormal pap smears, acetic acid solution test, which a vinegar solution is applied to the HPV infection and it turns them white, in addition to HPV DNA testing and biopsy. There are several different treatment options depending on how applied. So the patient can apply various creams, including imiquimod, podophylax, and syncatenicins, and as well as ointments. In addition, patients could have a provider-administered cryotherapy with liquid nitrogen, surgical remover with either laser, electrosurgery, or shave or scissor excision. There's also a TCA acid that can be placed on the lesions as well. One of the best ways to prevent HPV infections is by getting vaccinated. Patients can be vaccinated as young as 9 years old, and it's actually recommended to get as early as possible because data has suggested that the vaccine may be less effective the more sexual encounters patients have. And so by vaccinating at a young age, hopefully it allows the vaccine to be effective before the patient is sexually active. The recommendations for the vaccine is recommended up to patients through the age of 26, and when the age they are of when they're getting their first shot determines how many doses they would get of the vaccine. Patients aged 9 to 14 would get a 2-dose series at month 0 and then about 6 to 12 months later. If for any reason they did not get that second dose, or if it was less than 5 months apart, they would get an additional dose. Patients above the age of 15 complete a 3-dose series at month 0, 1, and 2, and 6 months. And now data does suggest patients between the ages of 27 and 45 may also complete the vaccine series, and this is based on clinical shared decision making for the patient. Genital herpes. So genital herpes is caused by the herpes simplex virus, and it's caused by HSV1 or HSV2. Most cases are caused from HSV2, and however, there has been increasing data showing that HSV1 has been causing an increased case of genital herpes, and about 70% of the population is HSV1 positive. HSV1 is less severe, and there's less shedding that occurs for the herpes virus, and typically has less than 4 reoccurrences in a patient's lifetime. It's important to note that unlike some of these other infections, herpes is a chronic lifelong infection that will not go away, that the patient will have the rest of their life. And then most of the patients, though, are asymptomatic. So the reason why it's a lifelong infection is because herpes enters into the nervous system and it does lay dormant into our central nervous system. And sometimes patients will have viral shedding that happens and it will cause to form new blisters on the skin, where other patients will have viral shedding but no new blisters form. And so patients are not aware that they are shedding and potentially spreading it to their partners. Oops, I'm sorry. I forgot to warn you guys. This is the last gross picture, I promise. So as you can see, the cases on the inside are more mild cases of herpes, whereas the 2 outer cases are more severe cases of genital herpes in patients. So the clinical diagnosis of genital herpes can be difficult because of self-limited recurrent painful vesicles are not always present, or patients are asymptomatic at the time, and so are not getting tested within that window. In the 2021 guideline, there's actually been a recent change to recommend that patients get dual testing and having a confirmation test with the bio-Western blot due to its increased sensitivity and diagnosis of patients with herpes. As far as treatment recommendations, the first clinical episode that a patient has, there's multiple different treatment options they can go with: acyclovir, famciclovir, valacyclovir, and normally it's just given for a short treatment duration for about 7 to 10 days. Some patients will be put on suppressive therapy, which they'll remain on for the rest of their life, and it will be a daily medication. And as far as which agent they select, it just really depends on patient factors, such as compliance with twice a day versus daily medications or kidney function, etc. Other patients are only on recurrent infectious therapy and whenever they're having an episodic event. And so most people are started or take their medication then when they're having prodromal symptoms, which is prodromal is kind of patients get this itchy or tingly sensation in the area where the outbreak usually occurs. And so they kind of just do spot treatments with the various medications listed here on your screen. So with STDs, really what one of the most important things is getting patients screened and tested. So that's where expedited partner therapy, or EPT, comes into play. So EPT is the ability to treat the sex partner of the patient who is recently diagnosed with chlamydia or gonorrhea. It does not require a healthcare provider to directly examine that partner, and so this can prevent reinfections from occurring and curtails further transmission. Across the United States, EPT is widely accepted, being permissible in 46 states and only potentially allowable in 4 other states. As far as EPT in Wisconsin, any physician, physician assistant, or certified nurse practitioner is able to prescribe EPT therapy. And in Wisconsin, we do have the ability to treat for chlamydia, gonorrhea, and trichomonas. It is important to note that EPT must be an oral medication regimen, that most data out there is for heterosexuals, and so data is very limited for men who have sex with men. What is the benefit of doing EPT? So EPT is beneficial because it has shown to reduce reinfection at follow-up about 20% for chlamydia and 50% for gonorrhea cases, and a lower risk of persistent recurrent infections, as prior, if sexual partners are not being treated, they could just continue to pass it back and forth between each other. There's no data currently to support the use of EPT for routine management of patients with syphilis. So given that EPT has to be an oral medication regimen, that makes it a little complicated given the new gonorrhea treatment recommendations that ceftriaxone 500 milligrams is the go-to agent. For patients diagnosed with gonorrhea, it's recommended that their sexual partner go to be evaluated by a clinician and receive the ceftriaxone 500 milligram dose. However, if a patient is unable or unlikely to seek timely treatment, in that case, it would be acceptable to prescribe Syphilis 800 milligrams as a one-time dose for those patients. We still treat for chlamydia infections in patients diagnosed with gonorrhea if the test result has not been documented. All right, our next patient case here. KP just tested positive for chlamydia. What steps should be taken next? Start her on doxycycline 100 milligrams twice a day for 7 days. B, have a prescription for doxycycline sent over for her boyfriend. C, abstain for sex for 7 days. Or D, all of the above. Perfect. Yep, it is going to be D. So since KP saw a provider, she is able to get that prescription for doxycycline, and her boyfriend is able to also get the same prescription to prevent that reinfection occurrence, and as well as abstaining for sex to prevent that reoccurrence from happening. So now we're going to really jump into the 2021 guideline updates that have happened, and really how this has affected clinical decision making. So first, we'll start with chlamydia. So prior, 1 gram of azithromycin times 1 dose was kind of the gold standard for what we use for chlamydia infection. And although azithromycin still does have efficacy against urogenital chlamydia infections among women, concern exists regarding the effectiveness for azithromycin for concomitant rectal chlamydia infections. And this can occur commonly among women and cannot be predicted by a reported sexual activity. So if azithromycin is used, post-evaluation treatment and testing should be considered, especially with patients that have rectal therapy, rectal infections. So in 2021, Dombrowski et al. Had an article published in IDSA, and it was titled Doxycycline versus azithromycin for the treatment of rectal chlamydia in men who have sex with men. Retrospective studies prior to this article had shown that doxycycline to be more effective. There was a meta-analysis of 8 observational studies that estimated the efficacy of 7-day doxycycline was 99.6% in comparison to 82.9% of azithromycin. However, the effectiveness of a regimen remains uncertain as there is no prospective study. So this was the first randomized double-blind placebo-controlled trial looking at the comparison of azithromycin versus doxycycline in men who have sex with men diagnosed with rectal chlamydia. The primary outcome that they were looking at was the proportion of participants that had a microbiological cure, defined as a negative NAT, in each study arm at 4 weeks. Secondary outcomes including looking also at microbiological cures at 2 weeks in proportion to those at 4 weeks as well. They did have some exploratory outcomes looking to include the proportion of patients that had a microbiological cure in subsets defined by HIV status, medication adherence, and rectal symptoms. And they wanted to also maybe study the impact of antacids and rectal lubricant or douching on treatment effectiveness based on a hypothesis that this may alter the concentration of azithromycin in the rectum. Patients were eligible to be included in the study if they were born male at birth, 18 years or older, and had at least 1 male sexual partner in the last 12 months. Patients were excluded if they had a concomitant untreated gonorrhea infection or syphilis infection, known allergy to tetracycline or macrolides, in addition to receiving antimicrobial therapy within the last 21 days of that negative test result. The study included 177 patients, and it did break these studies up into two different groups. So it looked at the completed cases, which was defined as CC, which looked at for the primary, secondary, and exploratory endpoints. And these were patients that were positive with NAT at enrollment and at follow-up NAT results, whereas the intention to treat population included all randomized patients. Microbiological cure was found at 4 weeks at 100% in patients treated with doxycycline, and azithromycin was only 74%, having an absolute difference between the two treatment arms as 26%. Microbiological cure at 4 weeks in the intention to treat group was 91% compared to 71% with the azithromycin group. They found that cases imputed for the intent to treat group, why doxycycline was much lower, is due to loss of follow-up of the 8 patients. There was 8 patients that had those negative test results. 7 were lost to follow-up, and only 1 participant had a positive NAT after the 4-week treatment period. Looking at secondary outcomes, looking at the difference between positive test results at 2 weeks versus 4 weeks. And so it did interestingly find that the proportion of participants with microbiological cure with the doxycycline group did increase from 2 weeks to 4 weeks, going from that 97, 94 up to 100%. However, with azithromycin, it actually did decrease. And the reason this happened, they are unsure. It was thought that maybe the azithromycin drug concentration in rectal tissue, it was found that it did remain above the MIC for chlamydia for at least 14 days, but given that these tests are 4 weeks later, maybe it does not remain above that MIC, and therefore it's not eradicating the infection completely. But the study was unable to determine what led to this difference at that 4-week period of success with doxycycline over azithromycin. One of the big concerns with doxycycline over azithromycin is that doxycycline is a medication that has to be taken twice a day for 7 days, compared to azithromycin is just a one-time dosed medication. This study did define sufficient adherence as if they've completed at least 9 doses of doxycycline within a 10-day period. And so while it's promising to see that rates were still very successful, it was hard to assess actual adherence to these medications unless the patients reported. Some limitations of this study included that it was almost entirely cisgender males, and so it's unable to report relevance for transgender males or women that have rectal chlamydia. In addition, it only looked at 2 regimens with the doxycycline and azithromycin. And so there are other studies potentially looking at alternative azithromycin dosing, especially similar to those ones with LGV, which LGV is a similar strand. It's caused by a particular strain of chlamydia, and they have been found successful with having a 3-dose once a week regimen for azithromycin compared to doxycycline. The next study is Duker's Mirror, and this was also published in IDSA. And they were looking at the effectiveness of azithromycin and doxycycline in uncomplicated rectal and vaginal chlamydia infections in women. This was actually conducted in the Netherlands, and it's known that rectal infections are common among women. So patients that do test positive for vaginal chlamydia, it's almost about 70% also have rectal chlamydia as well. And it's thought to be due to autoinoculation in the genital area. Prior studies have shown that azithromycin was less efficacious as compared to doxycycline for rectal chlamydia, 83 versus 99% in a meta-analysis observational study. And more studies, though, needed to be reported due to women are largely underrepresented in these patient populations. So this was a prospective multi-center cohort study that looked to see if azithromycin versus doxycycline for rectal or vaginal chlamydia had any significant difference. So the screening process was very unique in this, and patients were seen in an STI clinic, and only if they had they only had a rectal test done at that initial clinic visit if they had reported any unprotected anal sex within the last 6 months, or if they had current anal symptoms, then they did receive a rectal NAT test at that initial visit. Anyone at that visit that had reported anal symptoms or had unprotected anal sex were stratified into the doxycycline group, whereas any women that had a positive result from the urinary test was then stratified into the azithromycin group. Then at study enrollment, so which is coined T0, rectal and vaginal swabs were collected from these patients prior to starting their treatment. So a patient could have been diagnosed during this period now as having rectal chlamydia from that collected rectal swab, but they denied having that anal sex or any symptoms. So that is how patients could be on azithromycin and in the rectal chlamydia group. The primary outcome of this study was to look at the microbiological cure, which was defined as a negative NAT test at week 4. This study found that patients who were receiving doxycycline, so I'm sorry, let me back up a little bit. So there was 560 patients enrolled in the study, but only 416 were eligible for analysis due to some patients not providing samples at follow-up or missing samples throughout the follow-up duration. There were 341 patients in the rectal chlamydia group and 394 patients in the vaginal chlamydia group. Of these patients' population, 319 women, though, had both rectal and vaginal chlamydia. Microbiological cure at week 4 in rectal infections was 95.5% compared to azithromycin at 78.5%, with an absolute difference of 17%. Microbiological cure at 4 weeks for vaginal infections was 95.4% for doxycycline in comparison to 93.5% for azithromycin, with an absolute difference of 1.9%. This study also looked to see as a secondary outcome, because it's been found that a positive NAT at week 4 potentially only indicates the presence of remnant chlamydia DNA originating from dead chlamydia bacteria. And so they did look at those results as well in this study. And they did find that you possibly could not rule out that a negative NAT result was due to inadequate self-sampling. Some limitations of this study include that women were not randomized or blinded. It was based on clinical decision making as far as what group they were placed into. In addition, patients could have under or over-reported behaviors that may have affected findings. And so, especially with the doxycycline group, the actual proportion of cured may have been even higher, given that patients may have denied having anal sex and placed in the azithromycin group. Also, it's unknown whether these findings can be generalizable to other studies, given that this was participants for this study, young women, women with low education levels, and women of Western migration backgrounds were less represented in this study population. Overall, though, it did show that doxycycline did exceed azithromycin for the treatment of rectal chlamydia, and both of these studies were 2 big key articles that did prompt the change of having doxycycline as the recommended treatment for chlamydia. We also had changes in our gonorrhea updates. So gonorrhea is actually considered one of the 5 pathogens listed by the CDC as an urgent health threat to the United States. And it's on the 2019 antibiotic resistant report. And this antibiotic resistant report really serves as a resource of info on antibiotic resistance, and it provides the latest U.S. antibiotic resistance trends and highlights emerging areas of concerns and making sure that additional action is being taken. For gonorrhea infections, treatment has changed drastically over the last couple decades, and currently cephalosporins are the only class recommended for gonorrhea treatments. So back in 2007, we used to use, up until 2007, I should say, we used to use fluoroquinolones. However, they are no longer recommended due to higher rates of resistance that have occurred. So then starting in 2010, ceftriaxone 250 milligrams or Syphilis as a 400 milligram dose, in addition to azithromycin or doxycycline. The reason doxycycline and azithromycin were added was because it was found that the concomitant infections of chlamydia infections would be treated, and they thought it may potentially slow the resistance rates of gonorrhea from occurring. However, and about 50% of those patients that had gonorrhea did have concomitant chlamydia infections. However, 2 years later in 2012, Syphilis was no longer recommended in the guidelines, and that's because Syphilis does not provide a high enough or sustained bacterial blood levels like ceftriaxone does, and so it has limited treatment, especially for pharyngeal gonorrhea. Recommendation was to increase to ceftriaxone 500 milligrams times 1 dose. And that was because it was found that the MIC of gonorrhea cases has fluctuated, and the higher doses provide that greater level. So studies looked at doses that had the lowest ceftriaxone dosing that was 100% effective at eradicating gonorrhea infections. And from the various studies, they found about a 5 mg per kg dose, which would equate to about a 500 milligram dose, is how they settled on that number. This graph here shows that the rapidly developing resistance that's occurred over the last couple of years, and how medications like our fluoroquinolones and Syphilis are no longer recommended due to the resistance rates that have been shown. And then at the bottom of the screen in the green, you can see how azithromycin has slowly been creeping up, which also prompted the change to not have every patient treated for chlamydia, even if they test positive for gonorrhea. And this is another graph showing that MIC increasing and that's what's leading to those resistant patterns for treatment. So most ceftriaxone failures are due to that, as I already alluded to, that minimum inhibitory concentration. So for gonorrhea infections, for the MIC for ceftriaxone is 0.125 micrograms per liter. And it's fluctuated between about 0.1% and 0.4% of gonorrhea infections have shown to have elevated MICs to gonorrhea. So the percentage of isolates with elevated Syphilis MICs has declined in recent years, which is helped by the fact that it's no longer recommended as a first-line therapy agent for our patients with gonorrhea. So there is some potential hope for gonorrhea on the rising. So there are some new medications that are in the pipeline currently. So the first one is Zoloflotusin. So this is a new class of antibiotics, and it's in a class of oral spiropyrimidine thyroid. And it has a unique mode of inhibition against bacterial topoisomerase 2, and it binds at the sites at the bacterial gyrase, and it's distinct from those of other fluoroquinolones. It is found to be bactericidal, and it does have coverage against some other gram-positive, gram-negative bacteria and atypical pathogens. It is given as a one-time dose, but interesting, it's actually supplied as a powder, and so this one-time dose would be a solution that would have to be mixed up. So far, it's been relatively well tolerated, with the most common side effects reported having GI issues. Currently, it is in a phase 3 trial, and it's looking at comparing 3 grams of Zoloflotusin in comparison to ceftriaxone with azithromycin. The trial started in November of 2019, and it's estimated to be completed by July of 2023. The next medication in the pipeline is Jepotidosin, and this also is in a unique class of antibiotics. It's in the triazotine ethane group, and it's another type 2 topoisomerase 2 inhibitor, but it binds to a unique site on the DNA gyrase and topoisomerase to inhibit bacterial DNA replication. This also is an oral antibiotic, and it's given as a one-day dose. But this medication is currently being studied, looking at giving a one-time dose followed by a second dose about 6 to 12 hours later. Very similar to the Zoloflotusin, it is in a phase 3 trial currently that started in fall of 2019, and it's estimated to be complete in 2023. What's important to note with these medications is while there's encouraging data that has come out of their effectiveness against gonorrhea, neither Zoloflotusin or Jepotidosin has improved cure rates for pharyngeal infections. However, they have shown activity against fluoroquinolone and ceftriaxone-resistant strains of gonorrhea. Lastly, there potentially could be a gonococcal vaccine that does come out. So some studies have suggested that the meningococcal vaccine potentially provides 30% effectiveness against gonorrhea, and so there could be some substantial public health benefits, and this is currently being explored in the future. All right, last assessment question. Which gender should be on Flagyl 500 milligrams twice a day for Trichomonas? Is it males or females? Perfect. Yep, it is females. So prior to the guideline update, it was recommended that both were on 2 grams times 1 dose, and then it got changed to females should be on 500 milligrams twice a day dosing. This change occurred from a study done by Howe et al., which was a meta-analysis that included 6 articles. And the study really looked at qualities of deciding which articles would be included in this meta-analysis, wanting to be assessed on the bias of randomization, blinding, and loss of follow-up. They stratified studies as low, medium, or high risk of bias, and low was classified as having as if it was a blinded, randomized, and having a relatively small loss of follow-up defined as less than 25%. Of the 6 studies that were included, only 1 study met that criteria of having a low risk of bias. 3 had medium risk of bias, and 2 had high risk. Studies were included is also if they had comparison between single dose versus multi-dose Flagyl. The outcomes found in this group was treatment failure of all patients had a relative risk of 1.8% with multi-dose compared to single dose Flagyl. Of the 6 studies, one of the studies did have a smaller subset, or did have a comparison with HIV patients included in the trial. So they did have a sub-analysis group that excluded that one HIV patient population, and it did find a similar relative risk of 1.8. However, this study did have several limitations. A lot of the sample sizes were very small, and all but one of the studies were actually conducted before 1982, and clinical trial methods have improved vastly since then. A lot of this evaluations of side effects was not possible given that the studies did not all systematically assess them, given that the data is so old. In addition, a lot of patients were diagnosed with microscopy, which has very low sensitivity, as low as 48%. So while the data did show support for using multi-dose Flagyl, it is important to note those limitations in the study. So this graph just shows then the 6 studies that were included and that relative risk. There have been changes also to the pelvic inflammatory disease. So treatments are now including empiric broad spectrum coverage for likely other pathogens, especially noting that chlamydia and gonorrhea infections leading to PID has been decreasing, and there's other infections that can lead to PID. And so now it's recommending to add that Flagyl for our pelvic inflammatory disease to make sure that we're covering for our anaerobes, but it also does serve as bacterial vaginosis coverage as well. All right, and then to wrap up, so the ACIP, which is the Advisory Committee on Immunization Practices, now do recommend catch-up vaccines for patients over the age of 26 and between the ages of 45. In October 2018, the Food and Drug Administration expanded the approval range for these HPV vaccines through 45 for both men and women. And this is based on clinical decision making, regardless of potential HPV vaccinations prior to those age groups. So I know we went over a lot of information. What questions does anyone have?